Stark, my name. What will we cover today with this presentation? We will look introduction to our organization, just briefly. Then what is ELGA? How does it work? What content will you find in ELGA? What's the legal framework and the organizational consequences that are imposed out of that to the organizations coming from ELGA? And how did we implement that project? Then a look into ELGA, how does it look for the physicians, for the clinicians, and for the citizen himself when he looks into his ELGA? And then outlook into future developments. We are based in Innsbruck, which is here in the region of Tirol. This is the federal state of Tirol, all mountain area. And all of Austria has about a population of 8.5 million and lots of hospitals, medical doctors in hospitals, about 25,000. So lots of information for you concerning the Austrian healthcare system. Some impressions, because I get also reimbursement from the tourism office. No, just a joke. That you see how it looks like. Very similar to here, except the mountains are a little bit higher than here, but also so rocky with snow. And unfortunately, we don't have the sea. Tirol Kliniken is a big organization. We are all employed by the local government, and it's a government holding, and we manage 4 hospital sites in and around Innsbruck, of which the University Medical Center in Innsbruck is the largest one. Some key figures: we have about 2,500 beds altogether. Per year, about 120,000 inpatients, almost 2 million outpatient visits, and over 7,000 employees. This is a bird view of the University Medical Center here in Innsbruck. It's located within the city. Unfortunately, we don't have a lot of space to expand, also in height, because the airplanes are just coming in here. Now, what is ELGA? ELGA has been derived out of the EU e-health strategy. There is a digital agenda in the EU, and a part of the digital agenda is the so-called e-health strategy. And so each nation should work out, or should have already worked out and implemented a national strategy. And the core of the national Austrian e-health strategy derived from this EU e-health strategy is called ELGA. ELGA is an abbreviation for Elektronische Gesundheitsakte, electronic health record, which is always a term being used for cross-institutional exchange of information. ELGA is an information system that enables eligible users, all that are eligible, that's the patient himself, and all who are concerned or who are treating him. But nobody can just look into the ELGA of a person. There has to be a patient contact that is technically approved. So it has to be technically approved that this patient is now with this organization. Then ELGA will open up for them. Otherwise, ELGA is only open for the patient. All the patients, who is part of ELGA? ELGA is a so-called opt-out system. So in Switzerland, they have the opt-in system, and in Austria, we have the opt-out system, which means everybody that has a social insurance is automatically an ELGA participant, except he opts out. Social insurance numbers, people have social insurance numbers no matter whether they are Austrians or non-Austrians. Whenever they have a social insurance number in Austria, they are part of ELGA. And ELGA is divided into e-reports. That's basically also into the future when we look into images, everything except medication, and then there is the e-medication part. What does ELGA do? It's just a virtual medical record or virtual health record linking data already available at the different providers in specific memory locations. This is archives. This is not, nobody directly goes into the hospital IT systems, so we have special archives to provide the ELGA content for others to be fetched. And ELGA is just linking these contents so that people get an overview, where could I fetch from which organization which information. And as I mentioned, you need the technically verified patient contact. How is that being performed? In the non-hospital area, it is the fact of you show up at a general practitioner, you plug in, he plugs in your e-card, that's the electronic health card, where is no which contains no information, no medical information of the patient, only administrative information such as name, social insurance numbers, and like that. And putting in this e-card into the system will automatically create the contact via the central components of ELGA for this physician office and this day. The contact remains for 28 days after the patient left the office. And that's the way outside of offices, outside of hospitals. In hospitals, the fact that the patient has been admitted to the hospital opens up ELGA for this hospital, but for the whole, the total organization. All the hospital, all clinicians in the hospital. Of course, people should only and may only access and open up an electronic record and look into the ELGA if they have a patient contact and they need to do something with the patient. And we strictly monitor that. And the patient himself can see in his ELGA who has accessed his ELGA from which organization. Of course, the patient himself, via the ELGA patient portal, can look into his ELGA. ELGA started with the live operation in December 2015 with the hospitals of Styria in the Steiermark, which is the southern part of Austria, and the hospitals in Vienna. And step by step during the past year, other federal states were connected to ELGA, and our domain, we had order from the government, from the local government, to build up the ELGA domain for Tirol, for the hospitals. And we started with all our hospitals from Tirol Kliniken and one other provincial hospital in December 2016. And in the meanwhile, I tested with all the other hospitals and connected them to ELGA, so all public hospitals in Tirol are live in ELGA now. How does ELGA work? How is it structured? Here you have the hospitals or the healthcare providers, physician offices, let's say a hospital, and you need then a platform, a technological platform which is based on international initiatives such as IHE, International Integrating the Healthcare Enterprise, and this platform will connect the source systems where the ELGA content comes from to the ELGA infrastructure. We speak about domains, so we build up the domain for the public hospitals in Tirol. What is an ELGA domain? An ELGA domain is the lowest level where you have one registry and at least one or many repositories. That is where the data that have to be fed into ELGA can be fetched from. We have one registry in this domain, and the function of the domain is to create a domain-wide, that's the first level where you create a domain-wide patient index, cross-institutional patient index. Because normally the patient in one institution has the number 1, 2, 3, in the next institution a totally different number, and you have to connect these numbers. And this is being done by the domain-wide patient index. And across all these domains, the patient index of the domain are being connected to the central Austrian patient index. There is one central number for a patient all across Austria, and in this tree-like structure, the system can identify the patient all across the domains in Austria and pull together the data. Then you need the healthcare provider index. The system has to know who is a physician, who is a hospital, who is a laboratory, whatever. And then we have the access management system, which is highly complex. This provides and opens up the access to the healthcare provider where the patient contact is happening now. Then you have the auditing and protocol system, because the patient himself, via the patient portal, has to be able to look into his ELGA and see who from which organization has accessed his data. We use, for our ELGA platform, we use a system developed by an affiliate company from us. We founded this company in about 2000, and it is based in Innsbruck and is now part of Siemens worldwide. It still belongs 30% to us, but it's 70% Siemens, and it's called Siemens eHealth Solutions. I think they also have done already projects in Norway with that technology. They have connected all the mid-region of Denmark with it. They have done big projects in France, England, Spain, and so on. And of course in Austria, almost 80% of the domain software for the domains comes from Siemens and is this in Innsbruck developed solution. The repositories are also Siemens single share. That's being used as the ELGA repository. ELGA in detail is really very, very complex, and to build up such a system is not an easy task. Just a glimpse view, just a short view how complex it is. This is a description of these parts. Yeah, as I already mentioned, the mechanisms behind ELGA are non-proprietary mechanisms. They are international standards like IHE, Integrating the Healthcare. That's an organization coming out of HIMSS and RSNA. And its main purpose is to increase the interoperability between systems by defining typical workflow profiles, such as radiology workflow, laboratory workflow, and so on. And IHE is then again based on HL7, clinical document architecture, and DICOM for the images. Some important facts about ELGA. ELGA is based on latest international security standards. Everything is, of course, encrypted. We only communicate via safe networks all across Austria. No centralized repository. We have decentralized repository, despite the fact when you look into ELGA, it looks like the data would all be collected in one place, which is not the case. This is also a security feature, because if someone should be able to intrude somewhere, he only sees a part of the data, but it's really very unlikely that this system can be cracked. ELGA will start empty, no preload. The ministry didn't want that we preload and put in already existing data into ELGA, so whenever an organization is being connected to ELGA, it starts freshly, no data preload is allowed. Yeah, that I already mentioned. ELGA is an opt-out system. You can opt out generally from ELGA, or you can say, I don't want any e-medication information in ELGA, but everything else, or vice versa. And then it's important, if a patient is in ELGA for 5 years, he has data since 5 years, and then he has maybe a psychiatric episode, and he says, I just want to step out of ELGA for a while, and he re-enters ELGA then, opts in again, then he will restart with an empty ELGA. That's what the law required. It's no technical reason. And then we have to administer, which is a big challenge, the situative opt-out, which we cover later. And the links to the documents in the repository, that's also a legal requirement, no technical reason, will vanish or disappear after 10 years. So ELGA will only give access to data not older than 10 years, which in my opinion, makes not a big sense. But the ministry wanted it that way, and I already provided an improvement suggestion to the ministry to change that, so that people can identify data with their physician that they do not want to vanish after 10 years. They said they will do that, but currently we are in a election process in Austria. We will have elections, and currently the government has other things to do than to care about changing the ELGA law. I mentioned it already. To say that anybody can access the ELGA of a patient is wrong, because there has to be a proven patient contact, technically proven patient contact, so that ELGA will be opened up for this organization. Pharmacies, when you pick up e-medication at the pharmacy, pharmacies can only see the e-medication part, nothing else, and the contact will remain open only for 2 hours for the pharmacy. For the hospitals, for general practitioners, when the patient left the organization, the ELGA will be opened when he is being admitted to the hospital for the whole hospital stay, and always 28 days afterwards. But the patient can go home immediately, log into his ELGA portal, and take away that contact because of maybe he was not satisfied or something like that. And then the hospital or the physician cannot look into his ELGA anymore. Access login, so the patient has the right to see who has accessed his ELGA, when was this access, and it must be, the logging must be not only on an institutional level, but institution and person who accessed his ELGA. The benefit expectations connected to ELGA are optimized support of cross-institutional shared care, saving costs and time, eliminating double examination, avoiding additional costs, avoiding adverse drug events, and so on. Sustainable investment, highest level of security, and empowerment of the patient, because he will govern his ELGA. What will you find in ELGA? ELGA is based on CDA level documents. CDA is a HL7 standard, meaning clinical document architecture, which defines documents in fact as XML structures. ELGA defines 4 different structuring levels. EIS, ELGA implementation stage basic, is the discharge letter from the hospital as it is now, as a PDF, and surrounded by XML metadata. EIS structured, which is a wrong term actually, because it is still a PDF, but the sequence of the paragraphs in a discharge document are already as defined by the ministry, but it's still a PDF. EIS enhanced is an XML document. This is CDA level 2, everything structured, and full support, every detail is structured. Every diagnose, every lab value is being tagged by opening, closing tag, and with EIS full support, you could then make a graphical display of a lab value that comes from Vienna, same lab value from Innsbruck, another lab value from another hospital in Salzburg, and you could display it graphically because the system is able, because of the high structuring level, to pull out single information and show it graphically. This is the highest level, CDA level 3 documents. Some systems are already able to provide that, but not all systems. So currently we have a mixture of all levels, and this will remain for the next years because not all system providers are able to fulfill these high standards. But the final goal is to leverage or to bring everybody to CDA level 3. And which content can currently go into ELGA? It's only 5 information entities. The physician from inpatient stays, the physician discharge document, and the nursing discharge document if available. Nursing discharge documents must only be written if there is a nursing problem to be communicated. If there is a patient without any nursing problem, they don't have to write a nursing discharge document. From all kinds of stays, lab reports and radiology report, the report, not the images now. The images will follow. And e-medication. E-medication is on a hold now because there's a struggle between the Austrian Physician Chamber and the e-medication project, but it will continue next year with the rollout all across Austria. Other content will follow, such as pathology report, outpatient reports, images, immunization pass, mother-child pass, other content supporting cross-institutional patient treatments, such as for oncology patients, for example, or for chronic diseases like diabetes and so on. So lots of content will still be worked on. And finally, they are heavily working on something like a patient summary. So what physicians want is not just a collection of links to documents, to sift through documents. They want the most important facts about the patient, latest diagnosis, complications, risks, allergies, whatever, in a comprehensive overview, which is called patient summary. But the requirement for all the systems would be that they are able to deliver this content in the highly structured manner. So we are still a little bit away from that, but everybody's working on it. So the implementation guidelines, the reason why we are not allowed to throw everything just into ELGA is because each document and each information entity that goes into ELGA must be defined by the ELGA organization, which is like your government organization here that you come from. We have an ELGA organization all across Austria, and they define the content of the documents and the structure together with the ministry. And a content may only go into ELGA if this implementation guideline has been released by the government. And currently we have these implementation guidelines, general implementation guidelines, and so on, and we only have implementation guidelines for this kind of information that I was talking about. Other implementation guidelines will follow. One implementation guideline is finished, that's the pathology report, but the problem is that people are afraid to provide it into ELGA because they say, what if the patient sees a critical information before the physician was able to talk to him? Otherwise, the radiology report may go into ELGA. And as you know, also in a radiology report, you can have very critical information that is highly a problem for the patient, and he can look at it. So it's a mixed situation where they do not know now how to provide the pathology information. Further information guidelines will follow. The look and feel and the structure of the documents are now in Austria all the same. So when you speak about the CDA level 2 or 3 document, they will all look the same. They will have the same sequence of paragraphs, the same naming of the titles of the paragraphs, and a receiving system can automatically, in a highly structured document, pull out information automatically, pop it up. There was a patient problem, there was an allergy problem in this hospital. It could automatically pop up to the physician when he invokes such a document. What's the legal framework and organizational consequences? ELGA is a law, a federal law, and nobody can stay out of that. We all have to follow. The legal framework is much bigger, and the biggest challenge for us was organizational-wise to follow the law in this case, because the patient has the right to, he's an ELGA participant, but he can say at any hospital stay or at any visit to the physician, from this visit, I do not want anything to go into ELGA. This is the so-called situative opt-out, and we have to administer that. And with all the, in all visits that have nothing to do with HIV infections, psychiatric main diagnosis, genetic examinations, or abortions, in everything that has nothing to do with that, the patient has to tell us. We don't have to ask him. But in these cases, we have to actively inform him about his right, that from this visit, he has the right to say, I do not want anything to go into ELGA, which, if you think through that, that's very complex to handle in the hospital. How did we do that, the project? We split it into 3 sub-projects. Sub-project 1, making all internal systems like laboratory information system, clinical information system, radiology information system, ELGA ready to be able to deliver these kind of documents as CDA. Then sub-project 2 was setting up the domain and coordinating all the hospitals and go live with a subset of the hospital. And sub-project 3, which we just finished in May now, go live with all other public hospitals and attach them to ELGA, to our ELGA domain. Sub-project 1, making all the internal systems ready. Every information in ELGA must be coded, all the segments of the discharge letters and so on, each lab value. Then the CDA document generation had to be implemented. Then we had to submit 3 examples of ELGA documents for final validation before we were able to go live to ELGA GmbH in Vienna. Then we had to do extensive testing over 2 months with the ELGA GmbH in Vienna. And then setting up all internal ELGA support levels, support processes, and so on, responsibilities, very complex. Setting up the domain was also not easy to keep everything going with the project. We went live on the 6th of December in 2016 with 4 hospitals from our organization and 1 other hospital. And then these were the dates of go live for all the other hospitals, the public hospitals in Tirol, and finally we are live with all hospitals. Not with all ELGA relevant documents, because one hospital is maybe still not able to deliver the lab values because the system has to be, the vendor did not provide the ELGA documents and so on and so on. We still have a mixed situation, but we will push them to go live with all systems as soon as possible. And now, finally, just a look into ELGA from the hospital side. From our example from our hospital, we have Cerner Millennium. Cerner is a vendor from the United States. We have this system as our central clinical information system. And here you have one tab, which is called ELGA. If you click on that, you automatically leave seamlessly without having, you don't realize that as the user, you automatically jump into ELGA. This is the Siemens eHealth solution platform user interface. And when you click on it, within seconds, you get a list of where was the patient, which kind of information. He was in this hospital in Austria. There is a laboratory report from the 19th of January. And you get a list of available information, and when you click on one and invoke it, it will be automatically pulled from that archive, from this organization within seconds, brought to your attention, and with one mouse click you can take it over into your hospital system. To administer this situative opt-out, we have a sub-tab here. Then finally, the patient. How can the patient access ELGA? He can access it via the official portal of the Austrian Ministry of Health. There is ELGA login. You click on that. Then you need, of course, a computer, internet connection, and a citizen card functionality. You need electronic signature on your mobile phone, for example. Then you say, you click in with your mobile phone. Then you get, again, this screen with three fields. You log in, you enter your mobile phone number, your password, then you wait for 2 seconds, then you get a TAN, a transaction number, like in internet banking, and with that transaction number you can enter in your ELGA, but you have to do that within the next 3 minutes. You can then stay as long as you want into your ELGA. This is the ELGA user interface, the ELGA system portal for patients. Everything that's not medication, also in the future, images can be found here. Here you find the e-medication part. Here you see which healthcare provider still has access to your ELGA because you have been there, and you can take it away from him if you were not satisfied or something like that. Do it here. You can see the protocol, who has accessed my ELGA here. You could opt out from ELGA here or partially log out of ELGA. Look into the electronic record here. Every line is a document that has been provided by some organization, and this one you have hidden by yourself. The patient has hidden that document because he does not want that anybody except himself has access to that document. The problem is, the physician doesn't see that he doesn't see something. He just doesn't see it, which is actually not a problem because the logging can prove that when he looked into the ELGA, this information was hidden for him. This is the e-medication part. This is e-medication that has been prescribed, but not you were not in the pharmacy to pick it up. As soon as you go to the pharmacy, it will jump from the prescribed medication to the already fetched medication or picked up medication from the pharmacy. This is you see here who has still access. For 28 days, you can take it away from him with this pen and then signing off, TAN code, and then the contact will be closed and he cannot access anymore to your ELGA. This is the protocol. You see here also your own access to ELGA, the patient's access, but also from this hospital, Professor so-and-so accessed the ELGA. Outlook, the final slide. Yeah, what are the plans under discussion? We will complete the rollout all across Austria for public hospitals, nursing homes. We will try to increase the structuring level to CDA level 3 as quick as possible. Search mechanisms are requested by physicians. They want to be able to search in ELGA. Enriching with more content. For 2018, they plan the ELGA rollout for the general practitioners, especially with e-medication. And during the next years, also private hospital, private physician offices, dental medical physicians, they all have to be connected to ELGA. Mother-child pass, immunization pass are also subjects to be discussed. Supporting cross-institutional workflows, providing content is one thing, and the next level is then supporting cross-institutional workflows, processes. Then they are thinking about an interface so that also the patient's will declarations can be invoked via ELGA, which is very important for physicians, and expanding ELGA with personal health record functions, such as that the patient himself should be able to enter data, diabetes diary, for example, pain diary, or he could upload documents that he brought from abroad, which he thinks are important for ELGA. All this content that has to be provided by the patient, that will be provided by the patient himself, has to be specially marked because it's provided by the patient, maybe not quality controlled by somebody else. Radiation pass, there is a new regulation in the EU that says all institutions have to provide information about the ionization radiation that the patient gets over his lifetime, and ELGA would be the ideal place to collect that. And ELGA Plus project, opening up ELGA for other e-health mechanisms, like an application programming interface for ELGA functions. Yeah. Thank you very much for your attention.
Yes, I think we can. We have time for a question or two if you have. It's a coffee break afterwards, so I steal a little bit of that time.
Thank you very much. Thank you, sir. This was most interesting and inspiring for us in Norway. One question, does ELGA also cover mental health documentation?
Yes, yes.
I figured you'd say yes. And
yeah, I said yes, but we have to, mental health, if a psychiatric main diagnosis is being made at the patient, then we actively have to ask the patient, you would have the right that this information stays out of ELGA. Do you want to pull that right? But many people with mental health problems have completely pulled out of ELGA or have chosen a situative opt-out lasting for a year. This is the maximum that the law allows if someone is still an ELGA participant to declare a situative opt-out. I do not want to go any information into my ELGA from this organization for maximum 1 year.
But what if the healthcare provider has a document that they don't think the patient should see? We do experience that in psychiatrics. Can the healthcare provider opt out, or is it only the patient?
No, it's the patient's will.
Okay.
If the patient is not if the patient has I don't know, if the patient has a representative make the decision for him, a legal representative, then they have to try to connect to them and ask him. If he cannot be reached and the patient is an ELGA participant, then this information will go into ELGA. Afterwards, he can delete it from ELGA or hide it away. So,
Okay.
Yeah?
Okay, thank you.
One more question here.
Yeah, I was just wondering about the 10-year sort of lifespan of the data. Does that cause any problems with this research? Are you able to use the data for research?
No. ELGA is currently not thought for research purposes. It's mainly clinical. But currently we are in a process of structuring or planning the next years for ELGA, and I brought up as many others brought up the subject, what do we do with this data? Other concepts are cloud computing and analytics, and we will also have to provide something like that for ELGA. But currently the focus is mainly clinical and not research. Of course, the documents, only the links disappear. The documents in the different healthcare providers, of course, we are obliged to keep the documents and the information for 30 years minimum. So they still remain in our systems. Only the accessibility via ELGA will disappear.
Yes, it's very good.
Okay.
This was most interesting.
Thank you.
I can see that there are a lot of striking similarities here between us in Norway and you, not only the mountains, but also how this will probably look like in the future.
Yeah.
So now after the break, we will actually dive a little bit more into how this kind of functionality can be used and realized in Norway. So thank you, Mr. Christian Stark.
Thank
Here
you very
have a
much.
gift from us in Dips.
Thank you.
Thank you.
Thanks. Thank you.